I'm Dr. Robert Collins, Senior Endodontist at Riverside Dental Associates in Portland, Oregon. Or at least I was until I walked out of my practice last month, leaving behind 18 years of what I thought was an unblemished career built on precision, science, and an unwavering belief in the predictability of human anatomy. I completed my Doctor of Dental Surgery at the University of Michigan in 2006, followed by a 2-year residency in endodontics at the University of Southern California. I've performed over 7,000 root canals. I've taught continuing education courses. I've published 3 peer-reviewed articles in the Journal of Endodontics. I've seen shattered teeth, calcified canals, accessory roots in impossible locations, and dental abscesses that would make most people faint. I've treated patients who hadn't seen a dentist in 30 years, methamphetamine addicts with mouths that look like war zones, and children with genetic disorders that twisted their dental anatomy into configurations that shouldn't exist. But what I'm about to tell you is the one case that made me question everything I thought I knew about human physiology and ultimately led me to abandon the profession I loved more than anything except my own family. Riverside Dental Associates occupies the 3rd floor of the Morrison Building, a renovated 1920s structure overlooking the Willamette River. We're a 6-chair practice with 3 general dentists, myself as the specialist, 2 hygienists, and a rotating staff of assistants. The waiting room has floor-to-ceiling windows, expensive leather furniture, and an aquarium that cost more than my first car. We serve a comfortable clientele: insurance executives, attorneys, Nike employees from the nearby campus. It's the kind of practice where emergencies are rare and the schedule runs like clockwork. September 14th, 2024. A Tuesday. I remember because Tuesdays were always root canal days. My schedule blocked in 90-minute appointments from 8 in the morning until 5 in the afternoon. My first patient canceled, giving me an unexpected gap to review treatment plans and return laboratory calls. I was drinking my second coffee of the morning when Emily Dawson, our office manager, knocked on my door. "Dr. Collins, we have a walk-in emergency. Woman in significant pain. Dr. William Parker is booked solid, and she's asking specifically for an endodontist." I glanced at my schedule. The gap was there. "Send her back." The patient who entered my operatory 3 minutes later was a woman named Jessica Simmons. I recorded her age as 42 on the intake form she'd hastily completed. She was professionally dressed, gray blazer, cream blouse, dark slacks, with shoulder-length brown hair and the kind of exhausted expression that suggested she'd been in pain for more than a few hours. No wedding ring, minimal makeup. She carried a leather portfolio that she set carefully on the floor beside the dental chair. "Thank you for seeing me without an appointment," she said, her voice tight. "The pain started yesterday afternoon, and it's gotten progressively worse." "Tell me about the pain," I said, pulling up my stool. "Sharp? Dull? Constant or intermittent?" "Constant. Throbbing. Upper right side. It feels like someone is driving a nail through my jaw into my skull." Classic description of irreversible pulpitis, inflammation of the dental pulp, usually caused by deep decay or trauma. I had her point to the specific area, and she indicated the region of her upper right first molar. I made notes on my tablet while my assistant, Melissa Grant, prepared the examination tray. "Any recent dental work in that area?" "A filling, about 6 months ago. Different dentist. I just moved to Portland in July." I nodded. Sometimes fillings placed too close to the pulp chamber can cause delayed inflammation. The tooth tries to protect itself by laying down secondary dentin, but if the insult is too great, the pulp eventually becomes necrotic. It's a common scenario, and I'd treated hundreds of similar cases. The clinical examination began routinely. Jessica's oral hygiene was excellent. Minimal plaque, healthy gingiva, no periodontal pocketing. I checked her existing restorations. The filling on tooth number 3, the upper right first molar, was a composite restoration that appeared well placed, with no obvious marginal defects or recurrent decay. I tapped each tooth with the handle of my mirror. Teeth 1, 2, and 4 responded normally. Tooth 3 produced an immediate wince. "That's the one," she confirmed, her hands gripping the armrests. I applied an ice stick to the tooth. Prolonged, intense pain that lingered after I removed the stimulus. Textbook irreversible pulpitis. The pulp was dying or already dead, and the tooth needed a root canal. I'm going to take some radiographs, I told her. I'll be able to see exactly what we're dealing with. Melissa positioned the sensor, and I stepped out to activate the X-ray. The image appeared on my monitor seconds later, and I zoomed in on tooth 3. The radiograph showed a well-condensed composite filling extending approximately halfway to the pulp chamber. The periodontal ligament space appeared slightly widened at the apex, early indication of inflammation spreading beyond the tooth. The canal anatomy appeared straightforward. One mesial buccal canal, one distal buccal canal, one palatal canal. Standard configuration for a maxillary first molar. But there was something else. Something I noticed but didn't immediately process as significant. The filling material in the tooth showed a peculiar density pattern on the radiograph. Composite resin typically shows as a relatively uniform radiopacity somewhere between enamel and dentin. This filling had variations. Darker regions that suggested voids or different material composition, not unusual in itself. Different composite systems have different filler particle sizes and concentrations. The previous dentist might have used a layering technique or an older material. I returned to the operatory. You have irreversible pulpitis in tooth number 3. The nerve is inflamed and dying. I need to perform a root canal to remove the infected tissue, clean and shape the canals, and seal them. The alternative is extraction, but given your age and the tooth's position, I'd strongly recommend saving it. How long does it take? For a molar, typically 90 minutes. I can do it right now if you'd like. I have the time available. She nodded immediately. Please, I can't work like this. I have a presentation tomorrow. I explained the procedure, the risks, the follow-up care. She signed the consent form. Melissa prepared the anesthetic while I reviewed the radiograph one more time, measuring the canal lengths, noting the curvatures. Everything appeared manageable. The injection went smoothly. 3 carpules of 2% lidocaine with 1 to 100,000 epinephrine, posterior superior alveolar nerve block, and local infiltration. I waited 8 minutes for profound anesthesia, then tested the tooth with my Explorer. No response. You shouldn't feel anything beyond pressure, I told Jessica. If you do, raise your left hand immediately. She nodded and I began. Melissa placed the rubber dam, isolating the tooth. I removed the existing composite filling with a high-speed handpiece, excavating carefully to avoid perforating into the pulp chamber. The filling came out in chunks, revealing the access cavity I'd need to refine. Then I reached the pulp chamber and everything changed. The tissue inside the chamber wasn't the inflamed, hemorrhagic pulp I expected. It wasn't the necrotic, purulent material I sometimes encountered in teeth with abscesses. It was dry, completely dry, and it was black. Not the brown black of old hemorrhage, but a deep, uniform black like coal dust. I paused, my Explorer hovering over the opening. In 18 years, I'd never seen pulp tissue that color and consistency. Necrotic pulp could be gray, brown, sometimes greenish if bacterial infection was severe, but this looked like powdered charcoal. Melissa, look at this. She leaned in, her eyes narrowing behind her loupes. What is that? I don't know. I touched it with my Explorer. The material crumbled instantly into fine powder. No odor. Necrotic pulp usually has a distinct, unpleasant smell. This had no smell at all. I glanced at Jessica. She was staring at the ceiling, breathing steadily, showing no signs of discomfort. The anesthetic was working perfectly. I irrigated the chamber with sodium hypochlorite, watching the black powder dissolve and flush away. Beneath it, the floor of the pulp chamber appeared normal. Yellowish dentin, 4 canal orifices exactly where they should be. I located each opening and began the process of establishing working lengths. I inserted a size 10K file into the mesial-buccal canal, advanced it carefully until I felt resistance at the apex, then attached the electronic apex locator. The device uses electrical impedance to determine when the file tip reaches the end of the root, giving a reading that's typically more accurate than radiographic measurement alone. The apex locator beeped. I checked the display. 28 millimeters. I blinked, certain I'd misread. The radiograph showed the tooth's total length at approximately 21 millimeters. I removed the file, recalibrated the device, and tried again. 28 millimeters. Melissa, can you check this reading? She leaned over. 28. That can't be right. The radiograph shows. I know what it shows. I placed a rubber stop on the file at the 21 millimeter mark, the length indicated by the X-ray, and reinserted it. The file advanced smoothly past the stop, continuing deeper into the canal. I could feel it moving through dentin, navigating curves, descending far beyond where the root should end. I stopped at 28 millimeters and took a working-length radiograph with the file in place. The image showed the file extending to approximately the 21 millimeter mark, exactly where the anatomical apex appeared on the original radiograph. But I could feel the file's position. I could feel the resistance at 28 millimeters. I was holding the handpiece, and the file was physically 7 millimeters deeper than the radiograph indicated. That's impossible, Melissa whispered. I removed the file and tried the distal buccal canal. Same result. 27 millimeters on the apex locator. Radiograph showing 20 millimeters. The palatal canal measured 31 millimeters electronically, 23 millimeters radiographically. I irrigated again, checking for blood or signs of perforation. The solution returned clear. I was inside the canal system, I had to be, but the dimensions didn't match any possible reality. Jessica remained still, her breathing unchanged. I checked her vitals on the monitor. Heart rate 72, blood pressure 118/76, oxygen saturation 98%, everything normal. I sat back, my mind racing through explanations. Apex locator malfunction? I'd used the device on the previous patient that morning without issues. Radiographic distortion? Not possible to that degree with digital sensors. Anatomical variation? No variation could account for this discrepancy. I made a decision. I would instrument and obturate the canals based on the electronic measurements, not the radiographic ones. The apex locator was physically responding to tissue resistance. The X-ray was just an image, a two-dimensional shadow. I had to trust what I could physically feel. The instrumentation took longer than usual. I worked carefully using rotary nickel titanium files to shape each canal, irrigating copiously with sodium hypochlorite and EDTA to remove debris and smear layer. The canals felt normal, smooth dentin walls, gradual tapers, predictable curvatures. But they were impossibly deep, extending into space that shouldn't exist inside a human maxilla. After 40 minutes, I had 3 cleaned and shaped canals ready for obturation. I dried them with paper points, selected appropriately sized gutta percha cones, and prepared the sealer. Melissa mixed the resin-based sealer while I checked my measurements one final time. The obturation went smoothly. I coated each gutta percha cone with sealer and placed them to the working lengths I determined electronically. I heated a plugger and condensed the gutta percha in the coronal and middle thirds of each canal, achieving a dense, 3-dimensional fill. The warm gutta percha should have extruded slightly beyond the apex. It almost always does, even with careful measurement. I took a final radiograph. The gutta percha appeared to end exactly at the radiographic apex in all 3 canals. Perfect fills, not a millimeter of extrusion, textbook obturation. But I'd placed those cones 7 to 10 millimeters deeper than the radiograph indicated. I'd felt them seat. I'd condensed them. The gutta percha had to be extending far beyond what the image showed. Unless the image was somehow correct and my physical sensations were wrong. Unless I'd imagined the resistance, the depth, the measurements. I closed the access cavity with temporary filling material, removed the rubber dam, and checked Jessica's occlusion. Everything felt normal. I removed my gloves and made my notes, documenting the measurements and the discrepancy, though I wasn't sure what I was documenting anymore. All finished, I told Jessica. The anesthetic will wear off in 2 to 3 hours. You'll have some soreness for a few days, but the severe pain should be gone. She sat up slowly, touched her cheek. Thank you. When do I come back? 2 weeks for a follow-up. We'll check healing and place the permanent restoration. She scheduled her appointment with Emily and left. I stood in my operatory, staring at the radiographs on my monitor. Melissa had already broken down the tray and was setting up for the next patient. "What was that?" she asked quietly. "I don't know." My next patient arrived, a routine retreatment on a lower molar. The case proceeded normally. Measurements matched radiographs. Anatomy made sense. The world operated according to the rules I'd learned in dental school. By the time I finished, I'd half convinced myself that I'd misread the apex locator on Jessica Simmons' tooth, that the electronic measurements had been corrupted by some technical glitch I hadn't recognized. But I couldn't shake the feeling of the files in those canals, descending into impossible depths. The 2 weeks until Jessica's follow-up appointment felt simultaneously too long and too short. I thought about the case constantly. I reviewed the radiographs dozens of times, looking for something I'd missed. I tested my apex locator on other patients, confirming it worked correctly. I read articles about anatomical variations in maxillary first molars, searching for any documented cases of extreme root lengths. Nothing explained what I'd experienced. Jessica returned on September 28th for her follow-up. She looked healthier, more rested. The pain went away completely, she reported. By that evening, it was like nothing had ever been wrong. I took a periapical radiograph of the treated tooth. The gutta percha remained exactly where the previous radiograph had shown it, perfect obturation to the radiographic apex. The periodontal ligament space had returned to normal width. No signs of inflammation or pathology. The tooth had healed completely in 2 weeks, which was normal. I performed pulp testing on the adjacent teeth. All vital. I checked the occlusion on tooth 3. No prematurities. I examined the soft tissues. No swelling, no sinus tract, no discoloration. "Everything looks perfect," I told her. "You can see your general dentist for the permanent crown whenever you'd like." "Thank you again, Dr. Collins. You really saved me." She left and I sat at my computer, updating her chart. The case was closed. Successful outcome. Patient satisfied. By every clinical measure, I'd performed an excellent root canal on a tooth with irreversible pulpitus, and it had healed without complication. Except for the impossible canal lengths that didn't match the radiographs. Except for the black powder that used to be pulp tissue. Except for the feeling that I'd reached my instruments into some space that shouldn't exist. I tried to move on. October brought its usual flow of patients, root canals on anterior teeth, bicuspids, molars, retreatments of failed cases, surgical endodontics on teeth with persistent infections. Every case proceeded according to the established rules of anatomy and physics. Every measurement made sense. Every radiograph matched reality. Until October 19th, the patient was a man named James Anderson, 64 years old, retired accountant. Lower left first molar, tooth number 19. Symptomatic irreversible pulpitus with symptomatic apical periodontitis. He'd been in pain for 3 days, and the periapical radiograph showed a large radiolucency at the apex, clear evidence of bone destruction from chronic infection. I anesthetized the tooth, placed the rubber dam, and accessed the pulp chamber. The anatomy was immediately unusual. Mandibular first molars typically have 2 roots, mesial and distal, with 2 canals in the mesial root and 1 or 2 in the distal root. James's tooth appeared to have 3 distinct roots on the radiograph, and when I entered the pulp chamber, I found 5 separate canal orifices. Not impossible. Mandibular molars occasionally have aberrant anatomy. I'd seen 4 rooted mandibular molars, extra canals, complex morphologies. 5 canals would be unusual, but not professionally invalidating. I began measuring working lengths. The mesial-buccal canal showed 21 millimeters on the apex locator, matching the radiograph. The mesial-lingual was 19 millimeters, also matching. But the middle canal, a small orifice located directly between the mesial and distal roots, measured 33 millimeters on the apex locator. The entire tooth, from crown to apex, measured approximately 22 millimeters on the radiograph. I stopped, my file suspended in the canal. Melissa was assisting again, and I saw her glance at the apex locator display. "Dr. Collins?" I removed the file, recalibrated the device, and repeated the measurement. 33 millimeters. I could feel the file descending, navigating curves, moving through dentin that extended far below the visible root structure. I took a working-length radiograph. The file appeared to terminate at the radiographic apex, approximately 22 millimeters from the reference point. It was happening again. I finished the case in silence, instrumenting and obturating all 5 canals based on the electronic measurements. The 2 normal canals behaved predictably. The 3 aberrant canals, including 2 in the distal root that measured 28 and 31 millimeters, felt physically present but showed no evidence of their true depth on radiographs. James Anderson's tooth healed normally. I saw him for follow-up 3 weeks later, and the periapical radiolucency had decreased significantly. The treatment was successful by every clinical measure, but I'd worked on a tooth that extended into impossible space. I started reviewing my old cases, pulling radiographs and charts from previous years. How many teeth had I treated where the measurements seemed slightly off? How many times had I attributed small discrepancies to technique or angulation errors? I found 3 cases from the previous year where my documented working lengths were 2 to 3 millimeters longer than the radiographic measurements suggested they should be. I'd noted the discrepancies but assumed I'd made measurement errors. Now I wasn't sure. November brought a 3rd case. A woman named Amanda Richards, 57 years old. Upper right lateral incisor, tooth number 7. The clinical examination was routine until I accessed the pulp chamber and found not 1 canal but 4 separate canals branching from a common chamber. The radiograph showed a single canal. I measured each canal, 18, 22, 24, and 27 millimeters. The radiographic root length was 18 millimeters. I obturated all 4 canals. The post-operative radiograph showed a single, perfectly filled canal to the radiographic apex. I was becoming clinically proficient at treating teeth that defied physical reality. The patients healed. The outcomes were successful. But I was working in anatomy that shouldn't exist, navigating canal systems that radiographs refused to show, filling space that had no business being inside human jawbones. I stopped sleeping well. I'd lie awake at night, thinking about tooth structure, about the relationship between radiographic images and physical reality, about whether I was somehow losing my mind. I considered the possibility that I was having some kind of neurological event. Early onset dementia, brain tumor, psychotic break. I scheduled an appointment with my physician, Dr. Daniel Scott, and requested a full neurological workup. The MRI was normal. Cognitive testing was normal. Blood work was normal. Dr. Scott suggested stress and recommended I take time off, maybe see a therapist. I went back to work. On December 3rd, I treated my 4th impossible case, then a 5th on December 10th. Both followed the same pattern: routine clinical presentation, normal radiographic appearance, but canal systems that extended far beyond visible anatomy. I documented everything meticulously, knowing the documentation made no sense, knowing no one would believe me if I showed them. I began to dread root canal appointments. Every time a new patient sat in my chair, I wondered if this would be another one. The impossible ones looked normal. There were no warning signs, no way to predict which teeth would defy physics and which would behave according to the rules I'd spent decades mastering. Melissa noticed my increasing anxiety. So did Dr. Parker and the other dentists in the practice. They asked if I was okay, if something was bothering me. I told them I was fine, just tired, dealing with personal stress. They seemed to accept this, though I caught them exchanging concerned glances. On January 7th, I was treating a lower left second bicuspid on a patient named Christopher Hayes, 41 years old. The case had started routinely, but when I measured the working length, the apex locator showed 32 millimeters in a tooth that appeared 15 millimeters long on the radiograph. I was instrumenting the canal when Christopher suddenly opened his eyes, looked directly at me despite being reclined at a 45-degree angle, and spoke clearly around the rubber dam, the suction device, and my instruments. "You can see them now, can't you, Dr. Collins? The places where we extend beyond what shows in the pictures." I jerked back, nearly dropping my handpiece. Christopher's mouth was full of equipment. He shouldn't have been able to speak at all, let alone speak clearly. And I hadn't told him my name. He'd been referred by another dentist. and this was our first appointment. The roots go deeper than you think, he continued, his voice perfectly calm. Much deeper, into spaces that aren't quite part of the world you measure with your little instruments and your radiation images. Some of us have always been like this. We look normal, but we extend into places you can't see. You just happen to develop the ability to feel where we really are. I stood frozen, my hands trembling. Melissa was staring at Christopher, her face pale. Christopher closed his eyes and relaxed back into the chair, seemingly unconscious again from the anesthetic, though that made no sense either. You don't have coherent conversations while under local anesthesia. I finished the procedure in silence. My hands moved automatically, completing the mechanical steps I'd performed thousands of times. When I removed the rubber dam and Christopher sat up, he blinked and smiled at me normally. "All done?" he asked. I didn't feel a thing. "You're really good at this." I wanted to ask him about what he'd said, but I couldn't form the words. He scheduled his follow-up appointment and left. Melissa and I stood in the operatory, not speaking, for almost 5 minutes. "Did that really happen?" she finally asked. I nodded. "What did he mean? What is he?" "I don't know," but I knew I couldn't continue. I'd been working on people, or things that looked like people, who existed partially in spaces I couldn't measure or visualize. I'd been reaching into anatomy that violated every principle of human physiology. I'd been successful, clinically, but only because I'd been following measurements that led me into impossible places. How many of my 7,000 root canals had been on teeth that extended beyond normal reality? How many patients sitting in waiting rooms across the country had roots that descended into spaces between worlds? How many dentists, endodontists, oral surgeons were unknowingly working on anatomy that shouldn't exist? I submitted my notice to the practice on January 15th. I told Dr. Parker and the others that I was experiencing burnout, that I needed to step away from clinical practice for a while, maybe permanently. They were understanding. They offered to arrange coverage, to give me a sabbatical instead of resignation, to help me find counseling. I thanked them and declined. My last day was February 28th. I finished my remaining scheduled patients, transferred active cases to other endodontists in Portland, and cleaned out my office. Melissa hugged me goodbye, and I could see she understood, at least partially, that I was leaving because I'd seen something that made continued practice impossible. I'm writing this from my home office, where I've spent the last 3 weeks trying to make sense of what I experienced. I have copies of the radiographs, the chart notes, the measurements that don't align with visual evidence. I have Melissa as a witness, though she's agreed not to discuss what we saw with anyone else. I have my medical records showing I'm neurologically healthy, not delusional or impaired. I don't know what Jessica Simmons was, or James Anderson, or Amanda Richards, or Christopher Hayes, or the others. They looked human. They spoke and acted human, but their teeth extended into spaces that don't exist on radiographs, into anatomy that violates the physical constraints of human skulls. I think about the millions of dental procedures performed every year, the thousands of endodontists like me who trust their measurements and instruments. I wonder how many of them have felt what I felt, files descending into impossible depths, and dismissed it as technique error. I wonder how many patients walk among us with roots that reach into other dimensions, other realities, places that exist alongside our world, but slightly out of phase with the spaces we can measure and see. I'm not practicing dentistry anymore. I can't. Not when I know that some of the teeth I'd be working on aren't entirely part of this world. Not when I understand that the images we trust, the radiographs, the cone beam scans, the three-dimensional visualizations, only show us the parts of anatomy that exist in conventional space. I filed my notes and radiographs away in a locked cabinet, evidence that makes no sense, measurements that document impossibilities. Sometimes late at night, I take them out and review them, trying to find some rational explanation that would let me believe the world operates according to the rules I learned. But I remember the feeling of those files moving through canals that extended beyond visible anatomy. I remember Christopher Hayes speaking clearly with his mouth full of instruments. I remember the black powder where living tissue should have been. I still have my license. The Oregon Board of Dentistry has no complaints against me, no record of impairment or malpractice. I could return to practice tomorrow if I wanted. I could open the appointment book and start treating patients again. But I won't, because now when I look at people, at their smiles, their teeth, the bone structure of their jaws, I wonder what's hiding beneath the surface. I wonder what extends into spaces I can't see, spaces that only reveal themselves when you're holding instruments that reach deep enough to find them. The world is stranger than our imaging technology can capture. Some of us exist in more places than our shadows suggest, and some dentists develop the unfortunate ability to feel where we really end. I just wish I'd never learned to measure the spaces between what appears and what actually is.